When you first get into learning about breathing exercises, you see all these social media gurus showing their amazing changes with just one exercise. The birds chirp, the angels sing, and then you get to practice them and whoa, you don't see those same results. And you're thinking, I must just be terrible. Is that what's going on? No. What's going on is you're not getting a glimpse of reality because guess what? Your favorite social media guru fails. Because there's a dirty little secret in this industry that a lot of biomechanics people don't want you to know. And that's breathing exercises don't always work. Because most people out there are afraid to talk about their failures. And it's too bad because you can learn so much from working through a failure. But I'm not scared. And that's what we're going to do today is I'm going to run you through a case study where I did a bunch of various breathing exercises. I used a lot of my biomechanics assessments. And I didn't get amazing changes. So what did I do then? How did I help this person improve their symptoms? That's what you're going to find out. This case involves my social media czar and one of my coaches, both in my business and Elevate Sports Performance Healthcare where I work, Chris. What happened with Chris is he was performing a front squat, caught it awkwardly, and started to develop pain just below the left shoulder blade and into the side of the rib cage. And what would happen was he'd get better for a few days, go to lift, boom, pain would increase, and he just kept going through this cycle. And I remember one day I saw him, we played spike ball, and my man was having a really tough time moving around afterwards. I'm like, yo, we got to get this checked out. And so here's what's going on with Chris in terms of things that made his pain feel worse. Anything that involves rotation was problematic, lifting, sleeping, and the time of day in which symptoms were worse was in the morning. Generally, his symptoms felt better when he was lying on his back and at the end of the day. So the first thing I did in my assessment was find some movements that reproduced his pain, and the biggest ones that we saw were standing rotation. And you can see here as you watch the video, Chris is quite limited in his rotational capabilities. He experiences pain very quickly within the range. Then I performed some table testing. Here's what his measures looked like. So hip flexion was just above 100 on both sides. Straight leg raise was pretty good. Hip external rotation, 70. Hip internal rotation was 20 and 10, so we have a total arc of close to 100 degrees. Narrow infrasternal angle. With a narrow infrasternal angle, this is a very predictable hip rotation finding that you would see. And that's because those who have a narrow infrasternal angle or a narrower rib cage generally have greater amounts of external rotation available than internal rotation. Here's where things start to get a little interesting. You can see that we have a pretty big discrepancy in shoulder flexion. And the way I test this is I bias it so it's a little bit more external rotation heavy. You can see Chris has a 90 degrees on the left. And then if we look at some of his upper body rotational measures, external rotation is kind of within normal limits, but then you can see left internals, not too bad. This is pretty close to a total arc that we would expect. So this is about 155. That's pretty good. Normal is like between 160 and 180. But then we get a significant drop off in right rotation. This is 30. Generally, when you see these big side-to-side differences, you start to think that, maybe I'm dealing with someone who's developing a little bit of a rotational bias. And I will say, based on him being a narrow infrasternal angle, these side-to-side differences in this manner is very common. Knowing now that we have this big difference, you can see that we do have a slight asymmetry in hip internal rotation, with more IR being on the left, less being on the right. Again, for someone with a narrow rib cage, these are all pretty common findings. And then lastly, Ober's test was limited, minus 10 on the left, minus 15 on the right. All these findings, pretty common for someone with a narrow infrasternal angle. But what's interesting is the big discrepancy between how he presents on the table, which isn't that limited, compared to how he looks in standing. That's significantly limited. And this is likely because in standing, there's increased muscle activity because you have to fight gravity. And so that probably contributes to the loss of rotation. It's at least one factor. The other thing that stands out to me is the drop-off in shoulder flexion, especially on the left. When you see a loss of left shoulder flexion and right is better, and with some of the asymmetries that I mentioned in hip and shoulder rotation, that indicates that the left side of the body might be pushing forward posteriorly, which restricts motion, creates an asymmetry within the body. It's very normal. But given Chris's symptom presentation, it might make sense why that area could be overloaded when he rotates. But I will say I do have a bit of trepidation with this case. One of the biggest concerns for me is that Chris is dealing with some morning pain. Usually pain in the morning is associated with an inflammatory process. And the reason why is because the inflammatory system within our bodies shuts off a bit while we're sleeping. And then when you wake up, it ramps right up again. And that can be one reason why his pain is worse in the morning. So what I have to do is I have to tease out to what extent are his symptoms related to movement limitations, or is it more of an inflammatory process and we have to do things to mitigate inflammation? Even though Chris is an excellent coach and I teach him a lot, I don't trust nobody. So my first priority when I'm working with Chris is coaching him through the stack and restoring some of his internal rotation capabilities, which he needs as a narrow. If we can nail those two things, then my last course of action is to drive left rotation to hopefully reduce some of the asymmetries. The first move that I went with is a left offset walking wall squat. This move I thought would be useful because shifting the hips backwards is going to help improve internal rotation via sacral nutation. That's something a narrow and fraternal angle person needs to be able to do. Because he's going to be pitched more forward in a hinged posture, gravity is going to push the abdominal contents and air more forward, improving anterior expansion of the thorax and the abdomen. Let's see how that went.
These are going to be on the wall. Left foot on this, because I need you to get more ER on that side, because you got a lot of, you're getting more IR, right? So I want soft knees, hands on the wall. You're going to be looking straight ahead, silent in. Exhale, walk down as you get the hinge. So I don't want your hands like fixed, so that way you're getting an arch. So you want it to be like this. And I'm gonna have you squat just a little bit. You should feel back of the hips working.
So you want me to walk as soon as I
Uh-huh.
get
Yep, yeah, because you got the IR loss.
Yeah. Are we?
So my concern will be that you'll arch. Now I want you even. So you're gonna unlock both knees. Yeah, and so then silent in through the nose. That wasn't very silent, but we'll roll with it. Okay, Michael Myers. There you go. Exhale, look at the wall. Hips back, chest down. You're gonna go slow, this knee stays bent. Is that okay? No issues with the lat area? Okay, keep looking at the wall. I want you to just slowly walk down into a squat, but keep some pressure. Like you're a sloth. There you go. Good, so he's kind of rounding a little bit, like you're gonna sit in a chair, right about there. You feeling back of the legs? Try 5 breaths there. So silent in, long, slow. Push the wall, push the wall. Yes, there you go, Chris, nice. How was that? No problems? Can you just face the wall, try a quick turn? Not quick, but just I want to see how you did after that.
Yeah.
Still feeling it? Okay, let me see. Let me see going left. Still pretty sore? I want you to make sure you're looking at the wall and make sure you're pushing throughout, because what's happening a little bit is you kind of sag here. I want that. Yeah, yeah, that's fine. So soft knees. Okay, hang on. Come back up. You got to get the hips back way more. So you mostly bent at the waist. Open the door with your rear. That's where I want you.
I feel like I'm shifted though.
Shifted to the right? Well, you're asymmetrical. You're going to be a little shifted. Come back up. But that's the amount I want you to move. Because right now, what happened was you bent mostly forward. So soft. Hips back, walk, walk, walk. Eyes up, walk, walk, walk. There. Got back the legs. Shaking, this is good. Go ahead and squat down now. Keep walking. Walk, sloth, squatting. Like right there, brother. How we doing there? Is that all right? Awesome. Same 5 breaths, silent in, long, easy exhale. Make sure you're getting that reach.
Here were the results of that first exercise. First thing I checked was his standing rotation, and you can see it's not really all that different from when we first tested Chris. But let's see what happened on the table. See, overall we got some pretty decent improvements. His hip internal rotation is better on both sides. It's about 5 degrees better on the left, 10 degrees better on the right. Hip flexion was a pretty nice improvement, about 10 to 20 degree improvement on both sides. Got a pretty nice change in shoulder internal rotation on both sides, about 20 degrees more, but shoulder flexion remained unchanged. So although we didn't really get a change in standing measures, we did get some measures to budge. But what was problematic for me is we didn't really change shoulder flexion, and he still could have done better increasing his internal rotation. The other thing that was a bit of an issue with this is his symptoms were getting a little bit aggravated with that move. So it might have not been the best first choice for Chris. So what I decided to do this time was scale back. Now what I'm going to give Chris is frog breathing. And so the reason why I'm going to go with this particular move is because it does produce internal rotation in the arms and the legs, but because the arms and the legs are wide out in a more externally rotated position, it reduces the IR demands. The other thing that's cool about this is because he's more prone in this particular posture, it's going to improve lateral expansion of the rib cage, which is needed for a narrow, and it's going to take advantage of gravity in inducing anterior expansion throughout the body, which ought to improve his internal rotation capabilities. But did it? Let's watch.
Have a little bit more need on that right side. I want wide stance here like this. Eyes are going to look ahead, silent in. Exhale, push, breathe it out. Make your inhale really easy. I don't want that aggravating that area. Yeah. And then walk your knees back like a little bit. Yeah. Can you go a little wider? Yeah, there you go. Okay, palms are gonna be flat. Is this okay? Eyes are gonna drift right about there. I want silent in through the nose. You're gonna exhale, slowly reach. Eyes are drifting between the fingertips. Exhale, it's pretty good. Eyes right here, eyes right there. There you go. And so you're gonna get a little pressure into the inner knees, inner pressure, pressure into the inner elbows. Well, I'm liking this. Yes. Lots of shakes. Eyes gonna drift upward. Did you pace the exhale and reach, or did you just reach? Okay, just checking, just checking. It's pretty good. Yeah. Quieter inhale, homie. You would have died first in the newest Halloween movie.
Here were the results from the frog breathing exercise. Even further improvements in his internal rotation capabilities. Shoulder flexion improved slightly on the right. Left still kind of limited, but a little bit better. And we got a big change in shoulder internal rotation on the left. Sadly though, his standing measures still didn't change. But because we got some improvements in internal rotation and there was some increase in especially like right shoulder flexion, I decided, let's see if we can produce some left rotation with a very low intensity activity, a side lying same connect roll. So this is nice because the block is going to help produce posterior expansion on the left side, which is needed if you're going to drive left rotation. And the reason why I chose side lying is because if you're lying on your right side and rolling to your back, that's less left rotation than if, say, I was on my back and I rolled to my left side. And then because it's ground supported, my hope is that that makes it easier to perform the rotation pain-free. But did it? Let's find out how Chris did.
No?
No. I mean, yeah, I could, but it hurts. Just getting like even this turn right here.
Well, I completely on your side. Because right now you're twisting. Can you get that there?
Yeah.
Is that okay?
Yeah, we just get that.
That's okay there.
Yeah.
Grip your rib cage. Are you sure it's okay? I don't want to aggravate this.
Yeah.
Okay. You got a little bit of pressure? Okay. Silent in, roll to your back. You are straining way too much. I know. No, I'm just like, I'm not saying that to you. I'm telling myself that. Exhale. Yeah. It's got to be a little bit more flowy. Yeah. Is that okay?
Yeah.
You sure? Exhale, bring it back. Awesome. There you go. Nice.
Figure it out.
Yeah. Good. So you just gotta keep your right leg a little bit more chill, but I'm liking it. Just blah, blah, blah. Lazy here, lazy here. Just let it flop with you.
I'm getting it.
So apply a little bit more block pressure. I'll give you a little tug. How's that? Well, you can let your leg come up, right? I just don't want you digging.
Okay.
Yeah. So it's kind of like that, right? Yeah, that was your best one. That's it right there. One more. Rest. How was that?
Hard.
Keep your legs straight. I'm just gonna check your shoulder flexion here. That one too. You okay?
Yeah.
Okay. I know it's gonna be a little confounded with the Eric's pad.
How's that?
It's better. Do one more set, and we'll recheck.
Why that?
Because it gets you posterior expansion on that left side. So basically, I did 2 moves to try to get you to go back, so you could get some IR, right? And now I'm turning you into the left side. Because you still got the ER loss on that side, because you're pushing forward. So what happens is the lat's pushing forward, so you can't turn left because you can't expand into it. And then when you turn right, you got a concentric lat that making you more concentric to turn that way. You see it? But I had to get you some lower rib cage first,
Why are you turning left though?
based on the loss of shoulder flexion. Leg, right leg chill, right leg chill, right leg chill. Straighten your knee a little more. Yeah, just let it blah. There you go, nice.
Here were the results after the same connect roll. So you can see we got some improvements in shoulder internal rotation, and shoulder flexion actually budged a little bit more, which was great. But here's the problem. No change in standing measures again. And so you can see sometimes, even with good exercise prescription, technique, and changes on the table, you don't always get improvements in pain. So you have a little bit of a crossroads here. It's like, well, what do I do now? Basically, I have to experiment by trying a few different things. The difference between a lot of the moves that I had prescribed and standing is gravity. So I could go with something more challenging to see if that bridges the gap, but standing's uncomfortable. The other thing, logistically, is I don't know how much time I'm going to have left to coach him because I got another patient upcoming. Yeah, have to play to logistics at times. So if that's the case, and you still want to try to improve some symptoms, what you could utilize is a manual intervention, and that's what I did. So what I opted to do next was a manual therapy technique, because you can use manual therapy to try to get into a body shape or position that perhaps Chris can't readily access. I chose a manual therapy technique that drives more lateral expansion over that area. That's difficult for someone with a narrow infrasternal angle. So I did lateral ribcage expansion, and you're gonna see me troubleshoot a few different techniques to see if I can get an improvement in symptoms.
Give me a crack.
No. Silent in. Exhale. Is that okay?
Mm-hmm.
Easy in. Exhale. I don't like the leg position, but easy in. Exhale. One more. How's that?
Yeah.
Felt okay? Are you sure all the touch?
Oh yeah. More on your fingers and your thumb, but back too.
Like here?
A little bit. Like all the way. It's like all here and then kind of go all the way down. Here. All the way.
Yep, I got you. Hang on. Easy in. Exhale. Easy in. Exhale. Easy in. One more. Is that okay?
Yeah.
Try a line on your back now.
Come on, baby.
And that's better.
Yeah.
I just don't know if it's going to transfer to standing quite yet. Yeah, I mean, that's more. Try your standing twist one more time.
Why? Just because there's more.
I mean, that's my thought. I just tried to get you a little bit more of that same expansion.
I know, but I'm saying more demands standing. Is that what you're saying?
Yeah.
Won't transfer to standing.
Well, it's like you gotta tighten up to stay upright, right? We'll see.
Up there.
Okay. How about going the other way?
That feels like it's better.
So less symptomatic, but
I don't know, it felt really good.
good. Hang on. Silent in. Exhale. Actually, silent in. Exhale. Try your turn now.
It's better along there, but it's like more like scap.
Scap certain?
Yeah.
Okay.
But that it feels better along there though, like here. So that I'm still getting it like.
Put your arms up. Just sag a little bit. Look straight ahead. Not there though. There you go. Silent in. Exhale. And again.
Maybe like bar hang.
That's what I'm thinking. Try turn it now. Feet together.
Up there.
You didn't do as well as I would have thought. And then let me see the other side.
That one felt a lot better.
So after some manual techniques, you could really see stuff start to open up. And then when I went with the standing manual therapy technique, that's when we saw the most meaningful change in those standing measures. But the problem was is I couldn't replicate it with any type of exercise. I thought that maybe that hang technique was going to do the trick, but it didn't seem to do so. And what that basically tells me is that Chris currently doesn't have the ability to preserve some of those movement skills that I was teaching him in standing. And after I saw Chris, I kind of thought to myself, I wonder if maybe I had taped him, if that would have been a way to recreate the manual technique in standing. So I had him try that the next day. One of my buddies taped him up. And although you can see right here, he doesn't really get like some major range of motion changes like I did with the manual intervention, but his symptoms were improved and there was a slight improvement in his range of motion. So I had him wear the tape for a couple days. But really in this case, you can see like I exhausted just about everything that I could think of at that point in time. And so when I saw that, that basically led me to believe that one of the biggest factors to Chris's pain is likely the underlying inflammatory process. And so what I recommended to Chris after the fact was if he's still dealing with some morning pain, he's got to chill. He can't take a couple days off, then try to get back into lifting, especially if sleeping is uncomfortable. So I had recommended to him, do the moves. I got rid of the walking wall squat and I switched to a bar hang instead. I thought that might go better, but do the moves, take about a week off from lifting weights, since that was one of the biggest things that aggravated symptoms. You can do cardio, you can move as much as possible, and then do anything else that he could to help mitigate inflammation. So what happened? Was Chris still experiencing pain to this day? Did he never improve? No, he actually got a pretty nice change over the course of a week. He ended up seeing one of my colleagues, Fern, who's a manual therapist that works with us at Elevate, who did a few different manual interventions. And per Chris, although I don't have like a video of the changes, he felt a lot better. This was the next week after he had seen me. Doing that, coupled with doing the moves, which Fern recommended he do right after the manual treatment, Chris was able to play spike ball the following week, did so pain-free with no aggravation of symptoms. And so you can see, you don't always get major changes with people when you're doing some of these interventions. And that's why you have to expand your treatment repertoire well beyond just exercises. If I didn't have any manual therapy background, there was no way he was going to get some immediate symptom change. And you could argue, given that Fern got a good change with him as well, I probably should have done even more manual therapy. Also, too, you have to respect the inflammatory process. If someone is undergoing an acute injury, you might not get big changes in symptoms. The body has to heal itself, and that takes time. There's not really anything you can do to rush that process. But what you can do is provide a good healing environment for that person so symptoms don't continue to aggravate. I think that was part of the issue with Chris, was he wasn't letting himself do that. He would feel better for a couple days, go lift heavy, and then rinse and repeat. And that's why these symptoms persisted probably longer than they should have. You have to understand that pain isn't always that simple. It's not, oh, I see this biomechanics thing and I got to address that. There's a lot of factors at play that can contribute to why someone does or does not hurt, and it is your job to rule out what those possibilities are and try to push that person in a direction that's going to help them achieve pain freedom. Now, if you thought that case was pretty interesting and you're like, man, I'd love to see you troubleshoot other cases, then you definitely want to check this one right here, where I look at my buddy Kevin, who's an Olympic weightlifter, and he had some pretty significant shoulder flexion restrictions that were impeding his ability to perform a lot of Olympic lifts. And we go ahead and walk through that case to see if we can improve his shoulder flexion. You'll definitely want to check it out.